are going to be enlightened by her about male infertility, which is a very important topic when we are sitting in the OPD and dealing with the semen analysis reports. And, we have all kinds of reports right in front of us, and we are very, very puzzled about how to interpret them and what exactly should we advise to our patients when they come with an abnormal semen analysis report. Over to you, Abha ma'am, and please go ahead with your
Hello,
lecture.
good evening, everyone. I hope the initial hiccups are over and you can see my screen and hear my voice also. Is that right?
Yes, ma'am.
Okay. So what I'm going to say is we are all clinicians and a lot of us are gynecologists. And what do we need to know about male infertility? Because when we are treating infertility, we have to treat both together, the female and male infertility. What is the first test which we do to know that there is a problem? For the male, single point diagnosis is a semen analysis. And if it comes out to be abnormal, what do we do next? So first thing is we must know what is normal semen analysis. If we take the history of how semen analysis was standardized, then the first semen analysis was published, the manual was published by WHO in 1980. It was revised 5 times in 87, 92, 99, 2010, and now we have the 2021 manual. And from 2010-21, there are hardly any differences. But yes, they have changed the reference population. They have taken Asians also into it. They have taken few Africans. They are still less in number to represent the WHO 2021. But if you see, very small changes have happened. Semen volume 2010 was 1.5, 2021 is 1.4. So just by looking at the reference range, you can know from a laboratory that whether they have updated their reports or not, whether they have updated the technician who is reporting to know what is normal and what is abnormal. Total sperm number per ejaculate is 39 million. So if you take it in 1.5 semen volume, then it will come down to 15 million. Total motility was 40, is 42. Progressive motility was 32, is 30. Immotile sperm was 22, is 20. And vitality 58, 54. So it is almost the same. So we used to take 18 and now we take 15 as the normal semen analysis. This is the 5th centile of a population who's seen that in 1 year, the lowest sperm count, which has led to a pregnancy in unprotected sexual intercourse. So all you need to know is what is a normal sperm count. And if it is away from this, whether it is semen volume, whether it is total number of sperms or sperm concentration, motility, progressive motility is the most important part in motility. Normal forms, this is another very important part. So it is motility, count, and normal forms. So how do you evaluate a normal semen analysis? Suppose the motility comes lower than what we want. It is 12 million. So you will order another semen analysis 3 weeks apart. And you will take a detailed history in terms of any childhood illnesses, any surgical interventions in childhood, and later on, everything about smoking, drinking, whatever. And if there is no sperm in the semen, if it is azoospermia, you will send it again, confirm azoospermia by centrifugation of a semen sample at a minimum of 1000 Gs for 15 minutes and high-powered microscopic examination of the pellet, which comes after centrifugation. Now, G is the symbol written for RGF, or relative gravitational force. And this does not change with the radius or size of the centrifuge machine. Say if the centrifuge machine becomes bigger, the RPMs will have to be less. If it becomes smaller, RPMs will have to be more. But the G will remain the same. That is, gravitational force has to remain the same. So, I mean, automatically, whatever the size of the centrifuge is does not matter. 1000 Gs for 15 minutes, whatever pellet forms, that has to be seen under the microscope, and you find sperms over there, then it is not azoospermia. Now, what is abnormality in semen parameters? Either you get OAT. O is oligo, that means count is lower. A is astheno, motility, especially the progressive one is lower. T is tereto, where 4%, it is, I mean, normal sperms are less than 4%. Then you have one condition where you have azoospermia. You've got a centrifugation done and they say no sperm seen. Here, there could be two things. One is obstruction in the sperm passage, because the sperm has to come from the testes, cross the vas, and then come into the ejaculatory duct and be ejaculated out of the penile structure. So either there's no production or there is obstruction in the sperm passage. There could be only two conditions of azoospermia. And the third one is miscellaneous. Miscellaneous defects, I'm just saying obstruction in the sperm passage or no sperm production. There could be many reasons for no sperm production. It could be no stimulus from the pituitary, or there could be no sperm production from the testes, even with adequate stimulation from the pituitary. And the last is miscellaneous defects, where you find a very low volume, just 1 or 2 drops of semen, but the patient says, oh, I've ejaculated very well. 2 is very viscous semen. It doesn't liquefy. You keep it for long time, and yet, and the other one is that you find all the sperms have no acrosome over them. So this is globozoospermia. So these are the common defects which you find. And if there is severe oats or azoospermia, what next? So this much you've seen that, okay, it's not normal and it is really severe oats. That means the counts are 1, 2, 3, 4, 5 million, or say around that. Even asthenozoospermia is quite a bit, and you find that hardly 10% are motile, or teratozoospermia is there. What is the next? You do 4 things. One is hormones, and you just need 2 hormones, FSH and total testosterone. Any FSH greater than 8, the higher the FSH, more is the chances that the pituitary is working, but the testes are not working. And total testosterone definitely will start coming down. Imaging, there are 2 things which we need to do: a scrotal ultrasound to see the testicular volume and the Doppler flow, the blood flow in them. Number 2 is transrectal ultrasound, which is known as TRUS, for prostate and seminal vesicles, whether they are present, they are not present, whether there is obstruction over there. And all this, let the ultrasonologist report. You don't have to put your head into it. Just order these 2 things. I generally order only a scrotal ultrasound and get to know what is the testicular size, if there is complete azoospermia, and a FSH and total testosterone. These are the least hormonal analysis which should be in the armamentarium of a gynecologist. We don't need to do extensive testing. Another one is rule out retrograde ejaculation in low volume ejaculate. If the patient, the man, says that he did feel that he ejaculated well, where did all the ejaculate go? So is it going into the urinary bladder? Because both the openings are there. The urinary valve should close while he is having an orgasm. But sometimes there is incompetence of this valve, and hence all the ejaculate goes into the bladder. So we will have to rule that out. And genetic profile, if there is azoospermia or very little sperms, then we have 3 genetic tests. One is karyotype for Klinefelter syndrome, Y chromosome microdeletions, and cystic fibrosis gene mutations. Now, in this, these are all different things. You just can order these and sit back. You don't have to put your head, because you will have a good referral system in front of you what to do. So types of abnormal semen parameters, I've made it into a chart. It is either oats or azo or miscellaneous, like I told you earlier. And when there is oats, there could be mild, moderate, severe. When it is azo, I told you it could be hypo, testicular failure. In both of these, there is very low production of sperm, obstructive, normal production of sperm, but there's no outlet to sperms. And miscellaneous are different problems which you might find. So treatment of male factor again falls in these 4 groups. Lifestyle management is very important. If he's a smoker, stop. Alcoholism, stop. If he's sitting on very heated vehicles and driving a car always, that has to stop. Taking saunas, overweight. So, lifestyle management is very important. Medical management is the second, where you use medicines. Surgical management is the third, and ART is eventually the most important management today for male factor infertility. Lifestyle, weight reduction for obesity, decrease alcohol smoking, loose fitted undergarments, avoid occupational exposure to heat, frequent sauna, hot tub use, avoid anabolic steroids, which a lot of guys going to gyms use, and control diabetes. Then we come to medical management. Now, this is so important. I've given you 3 numbers: specific therapy, number 1, may help therapy, number 2, non-specific therapy, number 3. What is specific therapy? If you've diagnosed hypogonadotropic hypogonadism, or genitourinary infections, these have a very specific therapy, and this does improve the sperm count. May help is, one is in extreme obesity, you can use aromatase inhibitors, and 2, if you've done a reactive oxygen species assessment, then antioxidants can help if the ROS is high. Non-specific therapy is empirical treatment for idiopathic oats, where you can use anything and everything in the world. So severe oats or azoospermia, what a gynecologist can treat. Hypo we can treat. Infections of the genital tract we can treat. But if the infection becomes chronic, it's best to refer the patient to a urologist. We can also treat obesity with severe oats, even though we can refer these patients for bariatric and then they can come back. But otherwise, a gynecologist can treat. And antioxidants, if reason for high ROS is suspected. If we feel there are reasons that there could be high reactive oxygen species, then we can treat. How do we treat hypo? In gist, I'm giving you what are the clinical features. Low virilization. How do you know? Every man has a beard. You just don't know. Shaving frequency is very little. They take multiple days for at least this much beard to come that they need to shave. Then if they are examined hypertrophic testes, so you can just have an ultrasound or examine the patient yourself. And azoospermia is the clinical feature. Investigation, just low FSH and low testosterone. These 2 are important. LH is not mandatory. However, you can do all the 3 hormones. Causes could be congenital, Kalman syndrome, Prader-Willi syndrome. Acquired could be any pituitary injury, tumor, any pathology. So the pituitary is not giving the stimulus to the testes to make testosterone and sperms. What do we give here? HCG is the first choice. 1500 to 2000 units is given intramuscular 2 to 3 times a week. Now, HCG has the capability of having action for almost 48 hours or little more. So it is good enough to give 3 times a week for 3 months. Once we've primed it with HCG, then we can start FSH injections alternate day. And the dose is 75 units to 150 units, given for 6 to 24 months. So don't expect miracles to happen. It takes time. 6 months is the minimum where you start seeing in the semen analysis sperms coming. So this is what I've just given one example, where Hans et al. Clinical endocrinology showed that testicular growth in almost all and spermatogenesis happens in 80 to 95% of patients without undescended testes. So they should not be undescended testes. The testes should be in the scrotum, and testicular growth also happens. If you can see here, baseline is the dark one and the lighter one is post-treatment. That mean total testosterone has grown from 41 to 647. The testicular volume has grown from 24 to 33 centimeters square, and the mean sperm count has grown from 0 to 36 million. Then we come to the second thing which we can treat. And how do you know about genitourinary tract infections? This is also known as MAGI, because all accessory organs, prostate, seminal vesicles, or testes and urethra, anything could have the infection. First thing is, just don't go on a culture report. You ask the man if he's got any pain during urination, any frequency of urination, whether he has pain on erection or ejaculation. So any of these pains indicate that there is an active inflammatory process going on somewhere in the genitourinary tract. Then if a culture is asked for, let him collect only what he ejects out of his penile structure, not what falls over the prepuce and penis, which he collects in the container, because then it will have all skin contaminants. So in asymptomatic patients, the diagnosis is primarily based on leukocytospermia. So here also you don't do a culture first. It's very important to see peroxidase positive leukocytes. All granulocytes produce peroxidase, and this can be seen by a test by a reagent which is added to the semen which you've given for semen analysis. And if they see more than 1 million round cells, they have to do a peroxidase test which will show up all the peroxidase positive leukocytes, and hence we would know that these are not immature cells, these are infected cells. After you find a peroxidase positive leukocyte more than 1 million, then you order a culture and tell him how to collect. Ongoing infection should be identified and distinguished from post-infectious or non-infectious inflammatory diseases. So ongoing infections will have generally symptoms. They don't go without symptoms. Even touching the testes or a PR examination, which we ordinarily don't do as gynecologists, but they should be identified and distinguished from post infections. Like already some infection happened, was treated, and it is only now a little inflammatory disease. In addition to alteration of the basic semen parameters, sperm function and DNA integrity may be affected by chronic inflammation of the male genital tract. Adequate management.
Sorry to interrupt for a second. I think you
Yeah.
need to put the presentation on slideshow.
Okay, thanks. Thanks so much. Is it better now?
Yes, ma'am.
Yes. Okay. Thank you so much. Adequate management of affected patients appears mandatory. It's very important. So antibiotic treatment aims at eradication or reduction of pathogenic bacteria in the ejaculate. Available studies suggest that NSAIDs are effective in chronic inflammatory conditions. So we can give simultaneously NSAIDs. Low-dose corticosteroids may be needed. Sequential adjuvant treatment with antioxidants also can be considered as therapeutic options, but the first thing is antimicrobial therapy. And if there is pyospermia, then it has to be given for 6 to 12 weeks, nothing less than that. 2-week treatments don't work for male accessory organ infections. Fluoroquinolones like levofloxacin 500 milligram daily is the first choice therapy for chronic. It's like urinary tract treatment for females also. The fluoroquinolones are most important. These are first choice therapy for chronic bacterial infections because of their favorable pharmacokinetic properties at the site of infection. And what do these antibiotics do? They only eradicate microorganisms, but cannot reverse functional deficits or anatomic and secretory dysfunctions. Say if there has been chronic infection, then there's so much of fibrosis over there, and there could be secretory functions could be diminished. A lot of functional deficits may be there. So it can only eradicate microorganisms. So men with leukocytes in semen offer antibiotic treatment only if infection is identified in the genitourinary tract. So you can, after seeing leukocytes, a culture, palpation, maybe urologist should be referred to if you are unable to examine the man yourself. So do not hesitate to refer them to urologist if uncertain about what to do. So this is very important. Then we come to the third important condition which we gynecologists can treat after hypo and after infections: obesity and oats. If man is obese and he has got low sperm count or low motility or teratto, obesity may lead to physical disorders, genetic disorders, hormonal disorders, and all that in totality leads to erectile dysfunction and altered semen parameters and subfertility. What are the treatments modules? Lifestyle changes, diet, exercise, behavior therapy, pharmacological interventions, appetite suppressants, weight loss drugs, aromatase inhibitors. Surgical options are either offer them IVF straight away or just go for bariatric surgery. So here, the most important, apart from appetite suppressants and weight loss drugs, are aromatase inhibitors. And what do we do as gynecologists? We are quite familiar with aromatase inhibitors and we can use them very conveniently. Peripheral androgen aromatization is enhanced in men with elevated BMI. We all know androgens are aromatized into estrogens in the ovary also, in the fat also, in the periphery also, and in the liver also. Obese men show increased serum estradiol levels and lower testosterone levels because of this aromatization, which is happening all over the fat cells. So lowering E2 levels by aromatase inhibitors increases LH and FSH levels by pituitary modulation and increases testosterone levels. This is grade A evidence from a urological journal I've got. So if there is obesity and severe odds, obese male patients suffering from infertility seem to be good candidates for aromatase inhibitor therapy. What do we give? Letrozole or anastrozole may help to induce spermatogenesis in non-obstructive azoospermia and with low testosterone levels. So if you use anastrozole, it is 1 milligram daily, or letrozole is 2.5 milligram a day for 3 to 6 months. There have been some recent articles which show less frequency of letrozole to be used. Well, you will have to see what helps your patient. And the results don't come within days or weeks or months. It takes 3 to 6 months to find the TE ratio changing, the ejaculate volume changing, and the sperm concentration changing. So if they have to go on aromatase inhibitors without or with treating their obesity also, it may take good amount of 6 months. High levels of ROS. Well, we're not testing ROS so frequently in our laboratories. There's been a request in the 6th edition of WHO manual that this should be included in the assessment of infertility. But a lot of infertile men have elevated markers of oxidative stress in the form of reactive oxygen species. And this is a very favorite diagram which is there on the internet, and we've been using it from ages, that primary pathologies of male reproductive system is when these reactive oxygen species, O2, H2O2, and OH, these increase. These come from male accessory gland infections. So if the man is having infections or prolonged stasis of spermatozoa in the epididymis or in the transit, or there are a lot of immature and abnormal spermatozoa, they break down and they release all the reactive oxygen species. This acts on the sperm membrane, and it also leads to protein and DNA damage over here. And this all constitutes oxidative stress. What are the environmental lifestyle factors which can induce this? Drugs can also lead to this type of reactive oxygen species generation. Smoking, pollution, radiation, alcohol. Systemic pathologies are diabetes, cancer, systemic infections, varicoceles. So all this leads to oxidative stress, and this leads to spermatozoal dysfunction and infertility. Spermatozoal dysfunction happens due to either lipid membrane peroxidation and protein and DNA damage in the nucleus. So all over the sperm, there is damage. What are commonly used antioxidants after the insult is removed? You have to treat the insult first before you start giving antioxidants to reduce the oxidative stress. Vitamin E, 400 to 600 milligrams a day. Omega-3 fatty acids, 150 milligram a day. Or you can use L-carnitine, 3 grams a day. With L-acetyl carnitine 3 grams a day, or levocarnitine 2 grams plus L-acetyl carnitine 1 gram a day, and you will find it in all the products which are all over the horizon of Indian pharmaceutical market for male infertility. Coenzyme Q10. Coenzyme Q10 is used in 200 to 300 milligrams daily dose. Ascorbic acid 1000 milligram is effective. Zinc 200 milligrams 2 times a day. Selenium 200 micrograms a day. Pentoxyphylline 1200. So tablets are 400. You will have to use 3 tablets a day. Ethyl cysteine 600 milligrams a day, and N-acetyl cysteine 600 milligrams a day. These are commonly used antioxidants which can treat male infertility where we suspect that ROS would be high. Say in a diabetic male, you find that the diabetes is not well controlled, and if you get a chance to look at the oxidative stress, you find the DNA damage is there. Say you do nothing, but you do assessment of the DNA integrity and you find that it is more, then you can use an antioxidant apart from treating the cause also. So current evidence says that oral OA, what is it? Oral antioxidant supplementation for subfertile males improves chances for live pregnancy, live birth for couples undergoing ART. So we need well-designed studies to see which are the best candidates for antioxidant therapy and which formulation and doses will give us the best results. Having said that, when do you refer to a urologist? When there is a large or grade 3 varicocele on ultrasound with oats. So there has to be oats. Just a varicocele alone doesn't say that they need urological treatment. And this is the reason for having infertility. They should have oats. And this varicocele should be seen even when the patient is lying down. And now there are 5 grades. I've written grade 3. This is possibly the old grades which we used to look. Now there are 5 grades of varicocele. And just read the recent grades and you will know that in the grade where the varicocele is large, there it compromises with the blood supply of the testes. It also reduces the thickness of the artery which comes to the testes. And there are many mechanisms by which varicocele reduces sperm production. So if it is there, a urologist reference. If there is a need for reversal of sterilization, again, urologist. And Maggie, asymptomatic, symptomatic. If you're not sure whether there is infection or not, please refer these patients to urologist. Don't go on giving antibiotics on culture reports, which are mostly contaminations. When do you refer to an ART specialist? Azoospermia with high FSH, small testicles. Ultrasound diagnosis should be at least more than 2.5 cc. So there's azoospermia, FSH is becoming higher and higher, testes are smaller. Micro TISA may help these patients. 30 to 40% patients one might get to retrieve sperms with a micro TISA only, but for a normal TISA or TESI, we need larger testes. 2.5 cc is too small. Then azoospermia with absence of vas deferens bilaterally, which is BS-AVD. Here, because there is obstruction, there is a lot of sperm production, just a PISA, which is epididymal puncture and taking out sperms will help. No improvement after 6 to 12 months of medical treatment for hypo, obesity, or infection-related azoospermia or oral antioxidants for oats. So if you find all the medical treatment which we've given, whether it is hypo, whether it is obesity, it is infection, or it is oral antioxidants, and nothing has helped to improve the sperm count, these patients should be referred to an ART specialist. And when the diagnosis is in doubt, we don't know what is the reason for the low sperm count. You've not been able to identify a cause. Please refer them over if the sperm count has been persistently low while you are treating them or not treating them. So we conclude with this slide that oats, mild, specific medical treatment can be given. If you can find the reason, definitely. Otherwise, IUI, or last of all, IVF. Moderate, well, specific medical treatment again, but then IUI and IVF, ICSI. When you have severe oats, then specific medical treatment, there's no role of IUI, straight away go for IVF, ICSI. If there is azoospermia, hypo, you can treat with gonadotropins. And then once gonadotropins start generating sperms, timed intercourse, IUI or IVF or IVF ICSI, anything could work if the sperm counts are still low. Obstructive and testicular failure, straight away one has to go for either a TISA, TESI, micro-TESI or a PISA. Miscellaneous low volume retrograde ejaculation. Well, I have treated myself some patients where we ask them to pass urine first, alkalize the urine well by giving lots of soda bicarb, then ask them to ejaculate, and then ask them to pass urine, which is mainly semen, into a container, prepare it, and use it for IUI or IVF ICSI. High viscosity can be treated very well while processing the semen for IUI or for IVF ICSI. Globozoospermia, I really don't know how to go about it. I think IVF ICSI is the best choice for this. Donor insemination, we have to remember, is also an alternative, like we say oocyte donation, same way donor insemination for cases of male infertility. where there has been no access to medical, surgical, or ART treatment, or there is a genetic disorder or fear of transmission of a untreatable disease like HIV. So this is how we go for treatment of male infertility. As a gynecologist, I can do all this. Anything beyond that, I'll have to refer to a urologist. Thank you very much. I have two questions to show all of you, and I want all of you to unmute yourself. This is semen analysis is the first and generally only test done to detect male infertility. There are few semen reports tested at different labs. How will you find which one is most reliable? I'm just showing you a few reports. Can everyone hear me? Can you see the slide? Please unmute
Yes,
yourself.
ma'am. We can see the slides. Few of the reports are not very
This
visible.
slide. Huh? Reports are not visible?
Not very clear, but
Pass me out, come
few
closer.
of them.
I can see them. So you can see the report here. This is Lal. Now, what is it that will tell you whether this report is okay, or this report, or this report, or this report? How can you rely on which report? What is one test you see which makes you rely on a report?
Ma'am, morphology, maybe.
Very good.
Morphology.
Very good. So you see, what does this mean? Morphology normal. This has no meaning, right? Morphology, total percentage motile. Here there is morphology, 80%. This is the second page of the same group. 80% morphology, that means the technician is not trained to see good morphology, right? But when you see 6%, yes, you know this person knows how much is normal morphology. Same thing is in this report also. See, 80%, 50% normal morphology, not possible. Here also, you see the same thing, 52% normal, 2% normal. So morphology is one thing that you get an idea, and two is the reference ranges. If you yourself know the 2021 reference range or 2010 reference range, then you will be able to pick up that, yes, even 2010 is acceptable. But earlier than that is not acceptable because sperm concentrations were very high in those reports. So having said that, I have one more question for all of you. Mildly subnormal semen, will the first or second ejaculate make any difference? What is everyone's answer? Which is better, first or second?
Second, ma'am. Second, ma'am.
Okay. Nobody with a different answer? This is what I found. Sperm in the first fraction of ejaculate are more numerous, move more, and present better quality DNA than those lagging behind. This is the conclusion of a study that confirms that the objective of the first fraction is to fertilize the egg. So, see, we have so many misconceptions. Once upon a time, even I thought that the second is always good. Agar first में नहीं आए, second दे दो. पर जो fertilize करने वाले sperms हैं, वो first में ज़्यादा होते हैं. So these are two little things I thought I'll just bring to everyone's attention because this caught my attention also. I'm very glad that you all are participating in it. And
thank you so much, Dr. Abha. This was quite extensive and exhaustive. Male infertility itself to cover in half an hour is like almost impossible, but you have done such a great job so that
I've
we could
done all
understand.
what are we as gynecologists need to do. This is what I've
Yes.
tried to concentrate on. Because एक बार urological problems हो, then it's better to refer them either to a urologist or ART specialist.
We have few questions here, ma'am.
Yeah.
So Dr. Madanjit wants to know whether there is any role of alpha-zosine. It is a alpha blocker which is used in benign prostatic hyperplasia. So,
I am not going to even talk about it because this
yeah,
is not my
our-
domain. I would refer this patient straight away to a urologist to decide whether they need to be given a drug for benign prostatic hyperplasia. Madan
second
ji,
question.
अच्छे questions पूछो, please.
Second question by him is whether testosterone levels that we see would be total or free testosterone.
It is always total for males, and for females, it's always free testosterone. So for males, it's total testosterone you need to see.
And Dr. Madhura wants to know whether anything different that we should do in a case of globozoospermia. Is there a role of oocyte activation here?
Tejasvi, tell me what to do.
From globozoospermia,
You tell me what you would do. Because my embryologist is very afraid of a globozoospermia. He says that fertilization is very difficult in these cases. Say, what do you
Ma'am,
know about globozoospermia, Madhura?
ma'am, at our center, we had 2 or 3 cases. So in that, we have done plain ICSI only, ma'am.
And it worked?
Yes, ma'am. It did work in 2 cases, ma'am. We were able to, the number of embryos formed were less, ma'am. But I just wanted to know if anything apart from this needs to be
I
done,
don't
ma'am.
think
No,
that
what-
I don't think calcium ionophore activation is
Huh.
required. But please read about this and post it on this group. That
And
what does one
Madhura,
find in globozoospermia is because my embryologist is not happy to have globozoospermic samples.
sample for
He says
fertilization.
fertilization
Madhura,
is very, very.
you said that there were blastocysts formed in those cases?
Yes, ma'am. Yes, ma'am.
Okay. So you post
Maybe.
us any article where they show that good fertilization happens with Gitika. What is your opinion? I can see Gitika. I can see Latika Fogat also. Oh, wow. I'm so glad I sent you all the link today. Madhura, you will
Yes, ma'am.
post for us. You will post for us, okay?
Yes, ma'am. Yes, ma'am.
First fraction.
Globozoospermia, it's more important to know whether that patient could continue pregnancy or could be pregnant, actually.
So Gitika, find out everything.
Yes, ma'am.
Just put a
Yes, ma'am.
nice article like you'd put, I'll thank you for telling me about the vaginal progenova, estradiol valerate. I used it for a patient and it worked. Tejashree is still not convinced. She says you also gave the gel and gel works for a lot of people alone also.
We have
But
still
I
been
think
given to few patients, so let's
now
see.
I'll use it exclusively and then I'll say that yes, it is working. I used it just for, I think, 2 patients.
Give it to 2 of our patients. Both made good endometrium, but they were also given the transdermal gel. So we are
Yeah,
not very
we
sure
gave
whether
both.
what has worked.
Yeah. So we'll see what happens.
Yeah.
और बोलो?
Dr. Sunidhi ne पूछा है whether first fraction, maybe the 4 semen, like the first fraction ejaculate versus hind. Okay, not
See,
like
this
first.
is what I found. We have to confirm from more articles, but I also brought you a reference where they said the first fraction is supposed to cause a pregnancy. And a lot of times, a lot of us think that the second sample would be good, but I think I need to ask my embryologist also that should it always be the first sample which is better, or it is the hind sample which could also be good. I mean, in a semen sample, the first fraction can be taken in one and the second fraction can be taken in another container to see what is the difference in sperm count in both. But ejaculate doesn't happen just as a single ejaculate. It happens in a couple of ejaculates, to make a full semen sample. Tejashree, what is your...
Doctor, ma'am, I think the first sample is always the best. That's what we've seen in our labs as well.
Yeah, first is always the best.
Yes.
Someone else has to comment on this?
Ma'am, Nisha here.
Yeah.
Ma'am, sometimes it happens that if you don't have specifically in cases of severe oats and all, where you are seeing 3, 4 motile sperms. So we have seen that there is a difference when you take a second sample, 3 to 4 hours after the first sample. So there you might find a good, sperm, which is little bit better motile, and the fertilization rate is also better.
Nisha, put an article for this, please. We all need
Yes,
to
ma'am.
see what evidence says.
Sometimes it could be an inadequate ejaculation in the first go,
this is
and that is a
exactly
different
what I
thing.
was
We are
thinking. I
talking
did
about
not
the
say.
sample with a good
No,
ejaculation.
it's actually a second sample 3 to 4 hours after the first
But
sample.
that is
where
not
you have
known as a split ejaculate, no? That
Yeah.
is, you relax the patient, give him some relaxant, send him away. 3-4 hours के बाद आके देते हैं and they give a better sample. That could happen. But we can all read from what, we are all teaching and learning. Because I
Yes.
have learned so much from all these things, from these classes. So I would want you to put an article, and if we feel that yes, what you're saying is right, we will use it.
Yes, ma'am.
Dr. Anisha is asking whether is HIV in male partner an indication for donor semen, or
No.
can't we do ART after processing the sample?
Yeah. No, it's just not straight away processing. Anisha, first you look at the CD4 count and you look at the viral load in the serum. You can't see the viral load in the semen. So you see it in the semen, and we know the same reflects in the semen. So if the CD4 count is good, it is over, I think 350 or 450, and the viral load is almost undetectable, then we know that it is the lowest count, and then these people can be taken for IVF ICSI, though it is generally mentioned that it is best to take them on a different ICSI machine. You need to have a different place to process these. But still, I feel that double wash followed by ICSI reduces the risk of transmission to very, very, very small level. Hi, Latika. Good to see you. Unmute yourself.
Good
Muted.
to see you too. I've
Yeah.
just come to see you.
Okay.
I'm listening.
Okay, now what is the next question, Anisha?
So,
So you can do ART with processing the sample after you've confirmed that the load in the blood of the HIV is very low, DNA from HIV, and the CD4 count is good. Then one can process, and few labs do take up these IVF ICSI cases.
ma'am, Dr. Mayank wants to know your take on single versus double IUI.
Single.
Ma'am, can I add one thing for this?
Yeah, sure.
The HIV samples. Also, there is a requirement to have a separate storage tank for infected
Correct.
samples.
Correct.
So all the HIV and HBsAg samples, positive samples, you need to have a separate cryo tank for freezing the embryos also.
Yeah, this is normally normally the world literature guidelines say that even the ICSI table should be different, even the cryo tank should be different. So we have a cryo tank for all semen which has HIV or HCV or anything positive. HIV, we don't like to take much, but we have taken one case or no? We have taken a lot of IUIs as HIV.
We have done IUIs a lot, but
Yeah.
IVF we haven't.
But ma'am, when I was working in MEMC, actually there were guidelines that we cannot refuse a patient for ART treatment
Correct.
on the basis of HIV
In
positivity.
MC, you cannot
Yeah.
refuse.
Yes.
In
Yes.
private centers, we say that we
Yes.
do not have a different place for preparation, but IUIs, we do prepare in our own lab, and we do a double wash for them. Density
Yes.
gradient followed by swim up, and then we use them. But we make sure that the transmission, we have a consent.
Yes. Yes.
Despite this, you could get the infection. And IUI, if the CD4 count is good and the viral load is less, then there is no real chance of giving infection. This is mainly when the man has the infection and the woman is free, then there is all concern. If the woman have the infection, man doesn't have, then there's no concern about anything. So what is single versus double
Ma'am,
IUI?
Bhavani here.
Yeah. Yeah, tell Bhavani.
Ma'am, I just wanted to add one thing, ma'am. The latest ESHRE guidelines on HIV, semen preparation in HIV also talk about HIV RNA PCR.
Yeah, that is what you see in blood, no? Not only the quantitative DNA, but the RNA also, correct. So please add on this in the whole armamentarium, that we will look at the quantitative DNA load and the RNA PCR also to see the load. Correct? Is that right, Bhavani?
Yes, ma'am. This is also there in the new guideline. Though clinically we are not
Who's
using
doing
it.
a RNA PCR?
That's what, ma'am. I don't know, ma'am. Currently, it's not in clinical use, but they recommend that ideally it should be done.
But everyone must keep this in mind, that RNA PCR is now the new recommendation of ESHRE for HIV positive samples, and we need to even look into that before using the semen for IUI or IVF ICSI. ICSI is safer for these patients, leading to no transmission. Plain IVF is generally not undertaken because ICSI reduces the transmission even further. And then Mayank Jain, single versus double IUI. Single IUI is better, but if you are doubtful about the ovulation time, or you are doubtful about the LH surge, then double IUI could be considered, especially in AID. What is the new grading system for varicocele, ma'am? Chalo, koi batayega mujhe. Who's going to tell? Bhavani? Aditi?
मैम 5 grades वाला तो मैम
हाँ,
मुझे भी
5 grades वाला
नहीं
है
आता है.
आपने.
We'll have to look up and we'll post it.
Yeah, but practically it is mild, moderate, severe. It is so easy, you know. खड़े होके नहीं है वेरिकोसील, खांसी किया तो आ गया. दूसरा खड़े होते ही वेरिकोसील दिखा. तीसरा लिटा के भी दिख गया. So these are the grades which we followed with lot of ease. But now there are 5 grades. Let us post that also on this forum so everyone will learn. Is Deepika and this girl there?
Ma'am,
Deepika.
varicocele nowadays on ultrasound, they have added reflux. So if there is reflux, it is severe.
Yes, you are right.
Mhm.
So you know, reflux is the main thing which leads to arterial constriction.
Yes, ma'am.
That reduces the blood supply also. So Aditi, is anyone else there from my PGs? Deepika?
Yes, ma'am.
Yeah, so just read about all the 5 grades, what Gitika was telling us. Anyone
Yes,
can put it on the forum. Gitika, you can put it here also. Make
Yes, ma'am.
questions
Okay, ma'am.
and
I'll
we'll
put
get
it up.
all answers for these
Yes.
things.
Fine,
Anything
ma'am. I'll
else?
put it up.
Oh, any cutoff for HIV, RNA, PCR given? Come on, Yukti. Yukti's question, Bhavani, answer. Yukti, there is no cutoff for DNA qualitative. It's like undetectable. They say the HIV DNA is undetectable. That is the cutoff, in fact. For I don't know what is for HIV, RNA, PCR given. Ask
Yes,
Bhavani.
even I was about to ask that how do we interpret, but I think we'll
But
read
we're
about
not
it.
doing it as yet. No? We
We are
first
not doing.
do it and then we will interpret.
Okay, ma'am.
Anything else? So we've learned a few things, and please treat hypo if you diagnose them. Infections, treat them as long as you're sure that there is an infection. If you're not sure, just leave it. And obesity, we have tried letrozole, but today the couple which comes to you has no patience. If you tell them take it for 6 months, 8 months, they would in 2 months come back and say, do IVF for us. You know,
Ma'am, in obese males, only obesity is the criteria, or do we need to do a testosterone to estradiol ratio and then start letros?
ideally, a ratio should be done, but
नहीं वो
I
इसलिए
will
नहीं
tell
कह
you,
रही
there is
वो
no
इसलिए
ratio which is outlined by.
ए,
Hello,
Yes.
there is no ratio
अरे
which is
इज्जत समाज
determined.
में इज्जत कि इन्हीं के घर में रह के हुआ
Dr.
है
Rachita,
तो अनम्यूट
you'll have to mute yourself.
3 महीने
Sorry,
मेरे
mute.
को तो लगता है फादर भी हो सकता है बिकॉज वो बोली घर
Dr.
मैंने
Dave,
बोला
can you
तेरा
mute
4 बार पूछ
Rachita?
लिया मैंने
I'm
तेरा बॉयफ्रेंड है
unable
तेरा
to do
बॉयफ्रेंड है
that.
तेरा बॉयफ्रेंड है कह रही नहीं
Put
घर
the
में
mute.
मैंने
The
बोला कौन है घर
disturbance.
में शी डिडंट टेल
Rachita.
हाँ तो फादर भी हो
डॉक्टर
सकता है
विशाल प्लीज सबको म्यूट कर दो एक बारी फिर अनम्यूट करना मैम को
करते लोग हैं
हाँ, सबको अनम्यूट कर दो 1 मिनट को.
बेचारी बच्ची
Okay. What was the question? We were talking
Yeah.
about the cutoffs.
I was asking, ma'am, that is obesity the only criteria, or should we do this testosterone to estradiol ratio before starting letro?
Ideally, the ratio is described in most of the studies, but nobody says what is the ratio. So normal male estradiol levels are below 30 picograms. So if they go up and the testosterone levels go down, how much does estradiol go up? Depends on how much conversion is happening as peripheral conversion of androgens under the effect of aromatase inhibitor in the blood. So if the estradiol levels are higher than 30 or 35, which is a cutoff for men, then I think it is a good enough reason for us to give aromatase inhibitors for obese men. But
One
what is the
practical
ratio?
issue,
Nobody describes the ratio.
and one practical issue is that testosterone and estradiol have different units, and the
units.
conversion is a little difficult. Though there are softwares which say that we can just put the values and the ratio comes up, but practically it seems a little
Different
difficult
values
to
and different
calculate the
units.
ratio.
One is in nanograms. One is in nanograms, one is in picograms.
Online, it's very good calculator that is given for.
हाँ बोलो तनु बताओ, tell us.
Online there is a software thing in which we can put the testosterone and estradiol levels.
जिस यूनिट में है वो वैसे ही डाल दो, वो कैलकुलेट करके बता
कर
देगा।
देता है।
तो वो कैलकुलेटर प्लीज डाल देना हमारे इस फोरम पे तनु।
हाँ
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 so
मैम।
I put
today
that.
we've got lot of things which will come up. One is regarding this. Number 2 is varicocele. Number 3 was the RNA PCR, whether there's anyone who's doing it. Number 4 was what? What else we thought we will clarify?
Grades of varicocele, all 5
वो तो हो
grades.
गया, grades of varicocele हो गया।
मैम वो फर्स्ट एंड सेकंड इजैकुलेट वाला जो है
हाँ,
डॉक्टर
first
स्मृति
and
हैज
second
पुट
और-
दैट की सिक्स
And निशा जो तुमने बोला ना after 4 hours, that's not considered first and second ejaculate, okay?
Okay, ma'am.
Okay. So we'll see all these things and let us have these questions answered. So gynecologist treating male infertility is going to be better than what urologists treat. Okay?
Yes,
Can
ma'am.
we end the meeting now? I'm so happy that there were so many questions and we all were talking.
Ma'am, one more thing. Ma'am, what is your opinion regarding role of medical treatment in non-obstructive azoospermia? So many patients, they take gonadotropins. They come with history of gonadotropins for
You tell
non-obstructive.
me if the gonadotropin
There
levels
is,
are normal. See, in non-obstructive azoospermia, it could be unexplained also, Bhavani.
yes, ma'am.
Right? Most
Yes,
of the
ma'am.
things, most of them are unexplained where FSH is normal and testosterone is normal and I mean the pituitary is normal and the testes is normal and yet there is azoospermia. So I would say that these are unexplained ones and for them you can only treat them with antioxidants because ROS can be a reason for it and if they don't work in 6 months, they should be referred to an ART center.
Ma'am, there is a very, very nice chart given at ASRM site where they measure that what are the levels and what are the implications and what are the treatment. So I'll find it and I'll post
Yeah.
it on the group.
Chart for what?
Ma'am, chart for analyzing that whether it is obstructive and what kind of treatment will help or non-obstructive. Like various parameters are there. FSH, LH, testosterone. Yes.
Non-obstructive में जो real reasons हैं either hypo है या testicular failure है. अब इन
Yes.
दोनों के अलावा it is only very severe ROS का action हो रहा है, बहुत ज़्यादा oxidative stress हो रहा है, तो कभी-कभी you could get very low sperm counts as much as ESO or severe oligo. So let's see if you can find a chart for this. We'll know there are 3 things only which come with non-obstructive.
One more thing that Dr. Manu Gupta sir told us during posting that in non-obstructive, he had some cases of non-obstructive. It was a human reproduction update. Just micro TC was attempted and he was unable to retrieve. So for that patients also he gave HCG alternate day for 3 weeks.
Okay.
And one repeat micro TC were attempted. So it showed some counts better.
Tanu, anecdotal cases will be there, but we'll have to find out whether there is any study suggesting that HCG will help.
Update that I'll post on the
हाँ,
Yeah,
so
please
you can
post it because you know
post it.
HCG is a very important hormone, but if already pituitary is sending a lot of LH and FSH, then what will this additional HCG do? So when you do a micro TISA, maybe at one point you find nothing. You do a TISA again and you find sperms. So these are some
Focal spermatogenesis.
focal spermatogenesis, correct. So people do mapping of the testes and then they do at different areas. They try to retrieve TISA or micro TISA. Micro TISA mein to you see under the microscope, you see the tubules and you can pick up the tubule. So iska bhi do, we've got so many nice questions which we will have a nice chat on our group regarding all these questions. Okay?
Okay, thank you, ma'am.
Anything else? Mr. Dave, thank you so much for always being there with us.
Madam, only one thing I would like to tell. The number of participants which were you asking last time, actually the users which are registered on the viewer link, that data only we have. Right now, all the participants are on the presenter link. So that data we don't have.
Got it, Dr. Dave. We'll just share the viewer links to them from the next time.
The only concern with viewer link is, madam, I think chatting may not be possible. Support team chatting is possible on the viewer link?
Chat may not be possible, but the viewers that are watching on our viewer link, they might be able to send in their questions via chat box that is there. But
Or there is
currently,
a option
I
for
think
question answer
this
also.
two-way question answer is so much better than only sending questions. So it doesn't matter how many people are there. That's not.
ma'am, two-way question answers won't be possible on our viewer link.
Yeah,
But
I understand. I
but
understand.
then
No problem.
but one whoever is moderating, they can ask the questions over here and by placing it in the chat box, and you can
We
answer.
can
I
do,
want
and
I
will
want
we be
questions to come from people. I want interaction. So let it.
absolutely no, but will we be able to unmute them if required? Like if
No, they
somebody
would be on a different separate platform. They
No,
won't
no,
be.
no. We don't want that. I want a two-way chat.
Hmm.
We want
So
to
best
learn
is
and
presenter link.
teach both. We want to learn and teach both.
So Tejasvi,
So
the best is presenter link actually.
Yeah,
The thing
sure.
which you're doing right now.
Okay, done. We'll do that.
All right. Okay. Thank you
Thank
so
you.
much.
Thank you,
thank you,
ma'am.
ma'am.
Thank you for such
Thank
an
you.
active participation. I love this participation. I love it.
Thank
Thank
And
you.
ma'am, thank you for taking out time and for us it means a lot to us. Thank you.
Yes,
It
it
means a
does.
lot
It
to me.
means
And when I'm going through this, I can see so many people around, it's like lovely to see if you go across all the pages. So thank you so much. And we'll again come up with another topic. Who had asked me to speak on azoospermia or male infertility? There was a girl who put a request. That's why I brought this topic in. And you can put a request for the next topic and we'll go ahead. I want to take up general topics before, which are helpful to all gynecologists rather than only focusing on IVF topics. Okay?
Okay, thank you, ma'am.
Okay.
ma'am,
Bye-bye.
take care.
Yeah, bye. I'll see you in Bareilly.
Yes,
Okay?
ma'am, I'll see you.
Okay, bye.
Thank you.
Bye.